There you go.
Wonderful. Okay, whenever you're ready. Thank you.
All right, so this is really designed to be interactive. I want to hear your approach and what you think so far. Some of these cases you've probably seen similar, and I'm going to throw some curveballs in them too, but let's just get, we have here's Sharon too. Welcome. We have a 27-year-old patient. She reports injecting fentanyl several times daily. She ran out and wants to stop using. She feels unwell. Those are her vital signs. What do you want to do? Take me through this case.
So she looks to be a little bit tachycardic. Interestingly, her pressures are a little bit soft. Um, Sounds like she has a history of like pretty significant fentanyl use, and now that she's stopped and feels unwell with the tachycardia and a little bit tachypnic, I would think that she's starting to feel signs of like opioid withdrawal. Um, she's expressing interest in stopping using, so I think it would be a good time to like bring up a discussion about opioid agonist therapies like methadone and bupe that we can start if she's interested.
Great. And so in the past, she has used buprenorphine, and it did actually help her. She's nervous about it because in the past she was on heroin, and now with fentanyl, she hears there's a lot of precipitated withdrawal. And so, but she's willing to try it. So what would you like to do next?
Feel like this is where maybe have a conversation about both, what we think the risk of precipitated withdrawal is. So maybe trying to formally score her on like cows or something like that to kind of risk stratify her readiness for initiation of buprenorphine, and then talk to her about some of the strategies we could employ. If she does start to withdraw, including additional buprenorphine or like full agonists. I know that may be somewhat controversial, but just kind of working on a shared plan about if we get into a bad spot, how we can help move forward.
Cool. So you mentioned cow score. That's perfect. This is what the cow score looks like. Um, and you've seen this before. And Sharon, I don't know if you can speak, but if there's any, this is like interactive. So if you want to weigh in on cases, feel just jump in. So this is what the cow score looks like. And I think kind of the most important thing is the very bottom is like how you score it. So below 5 is really not withdrawal. 5 to 12 is mild, 13 to 24 moderate, 25 to 36 is moderately severe. So this is how you score it. And we're going to talk about, it might not even be necessary to use this scale, but we'll get to that in a moment. But let's say that her score is like, let's give her a 12. All right, and again, she's interested in buprenorphine. Yeah, what do you want to do next?
I would start her on bupe, and I think it's important to let people know, like kind of what Brennan was alluding to, that if we did precipitate any like worsening withdrawal, we can give more bupe and kind of get her out of that into a better spot.
So give me specifics. How much are you going to give her? When are you going to reevaluate her? Like how would you approach this?
Uh, it's a good question. I'd probably start at like 8 of Suboxone, like sublingual tab, um, and then see how she feels. I know there's some talk about like starting higher, but I think with like mild withdrawal, I would see if that does the trick.
And when would you reevaluate her?
Then maybe like 30 minutes later.
Okay, and what are you looking for?
And I'd probably just score her again on the cows and see if that's affected her symptoms at all of withdrawal.
Yeah. Have any of you had experience with this so far? Have you started people in the ED?
I have, so thankfully I have not actually precipitated withdrawal. People have been pretty far along before we started. So I haven't had to do as much of the contingency management. And I don't remember. I know that we do have ED protocols, so I think I ended up just like looking up that in terms of like our dosing initiation. I want to say that we, at least like when I had done it a couple of times last year, started like even lower, like maybe even like 4. But I can't remember exactly. And then, yeah, I think the strategy was like, you could continue to like up titrate up to like a total of maybe 24 milligrams in a 24-hour period or something like that. And then typically I think people are discharged on like 16 to 24 or like take the take home kit where they kind of self titrate.
Yeah, perfect. Okay, we'll talk about all that. And so let's just say that we gave her 8 milligrams. She feels much worse, and she says, "I think I might be allergic to Suboxone." All right, so this protocol, I love this protocol. And so you mentioned the one we've got in our system currently, and it's outdated. It was really created around the time of heroin and not fentanyl. And so we've just approved an update to it, but it's going to take a little while before it gets all rolled out. But it looks like this. This is the California Bridge protocol. So if you were at Liz's talk, like she works with Bridge now, and so this is the protocol that they use. And the other thing that I like about this is that they update it as needed, and the last update was about a year ago, but they do update it. So I'm sorry this is busy, but it is worth going through it. So the first thing is I just find it myself. I just put in Google like Bridge buprenorphine start, and it pops up. That's how I find it. I don't remember any other way to get it. But first of all, are they in withdrawal? And you already answered that as far as like the COWS score. So um, you can use the COWS score, but the current recommendation is look for 2 clear objective signs that you don't attribute to something else. They're diaphoretic, they're yawning, they've got goose pimples, they're like tachycardic, they're vomiting, like something objective. And then just ask the patient, are you in withdrawal? And patients tend to know if they feel like really bad. And that's so if you get these objective signs and they feel unwell, that's okay to start it. We've spent all this time about like, okay, COWS score. Do you start with 4 or 8 or 10 or 12 or 50? Like nowadays, it's just like you as the clinician see their objective signs and they feel shitty. You can start it at that point. All right. The way that the recommendation is currently is if they're in that withdrawal, kind of go big. So the thought right now is that fentanyl is so potent and it's so lipophilic that it binds onto the receptor, it stays around for a long time. You almost want to hit them with just a bigger dose up front. And our current recommendation is for this. We're calling it macro dosing, is what some people will call it. Give them 16 milligrams right up front. Um, I'm okay with you giving 8, but I don't want you to use 4 anymore. 4 is like we're starting to say like it's either 0.5 or 16. Like those are the 2 doses to start people with. 8's okay if you reevaluate quickly and you can give more if they're having difficulty, but really kind of go big or go home for this now. And because of the ceiling effect and the way we know that buprenorphine works, it's safe to do so as well, especially in a patient that's got opioid tolerance, particularly people that might have had experience with buprenorphine in the past. Just go for it. If their withdrawal's improved, you actually want to give another dose. And so if I gave 16 up front, I would give another 8, and then I would send them home with the pack, which we'll talk about in a second, but and have them take either 16 or 24 milligrams per day until they get to the Bridge clinic. That's how I would play it. If their withdrawal is not improved, then you have to think, okay, did I precipitate withdrawal and I need more buprenorphine? Is there something else going on? Like maybe they've got co-occurring use of stimulants, and that can also produce very similar symptoms to withdrawal. Maybe it's a side effect of buprenorphine, like nausea. So I'm going to treat that. And then never, ever, ever forget about anchoring and like these like patients that are actively using drugs, including like injection drugs, they're at high risk for infections and endocarditis and bacteremia and stuff like that. So if they're not improving, you got to think like, okay, maybe there's something else going on. I'm going to go talk through more, but any questions so far?
This is great. And yeah, I wonder like as we work on updating protocols, like what plans there are, or even like how we can help facilitate this as the residents often prescribing with pharmacy. Because I have found that both for Suboxone and for methadone in the Brigham ED, there's just like a lot more hesitation and like people erring on like not erring, but people wanting to lean towards much lower doses than on the MGH side, where I feel like our pharmacists are like very kind of up on the literature and current trends, very comfortable with these medications. If anything, actually advocating to be kind of more aggressive than sometimes other providers are like ordering things as. So I'm just wondering like if there's any way we can use the changing of protocols to like really connect with our pharmacists on some of this and make sure everyone's comfortable with this.
Yeah, let me turn my lights again. Right, they turn off. No, love the point, and I think part of the reason is history, because the dosing is changing, and the second is just comfort because of frequency. Like we just don't see that much at the Brigham compared to the General or even the Faulkner, and so I think that the pharmacists are not as comfortable. In this whole process for updating the protocol, Kaylee Marino, who's our director of ED pharmacy, has been very much involved. So she's on board with it. In fact, the two of us are working on updating the patient instruction form for this. So the fact that she's on board, I think, will be really helpful. But we all know the reality, which is that you'll be working at 2 a.m. with an ED pharmacist that probably didn't read the email, right, or something like that, and so can absolutely really use your assistance with that. What we're going to do is we'll have a new protocol. We're going to update the order set too. So like hopefully between the two of those, you can say like, look, this is what the protocol is, and this is even what the order set in Epic looks like. That will kind of smooth that over. But Brandon, I think your point is completely accurate, that it's not going to be like very smooth. So yeah, could really use your help with just promulgating this, and even just like what we're doing today is just talking about this. I think this is helpful to help spread the word, because you might see a patient tomorrow and use something like this. The other thing that would be helpful is getting success stories when people actually do well with it and they don't have precipitated withdrawal and they get started and they're doing great. So sorry, go ahead.
No, now that also makes me think of a second thing, which I thought yesterday, one of my kind of things I walked out of the room with was like, oh, I really like the idea of feeding back the success stories, like when people are referred to the Bridge Clinic or if people fill their next prescription or something like that. I wonder if that would be actually if something like that's already happening, or like I feel like that could also be like a low-hanging fruit resident project of like, this group of people becomes the cheerleaders for others in the department, prescribing, methadone or Suboxone, or referring people to Bridge Clinic and kind of following up on those charts and kind of sharing some of the success stories. But that was what you just made me think of. And then the other question that I had that I feel like I have encountered is like someone is worried that they may precipitate withdrawal and don't want to start Suboxone now, or they're in pain because of their abscess or other injury, but they want to start Suboxone as kind of their longer term maintenance therapy. And the question becomes, do you give methadone now and then plan to bridge to Suboxone later, or in practice do we find that we don't have a protocol or kind of enough time with the patient to successfully transition them from methadone to Suboxone, and we discharge them with nothing? And I'm just wondering, like, should we be thinking about that, counseling patients about, taking that 10 to 40 milligrams of methadone in the ED if their goal is to ultimately be going out on Suboxone?
Yeah, great question. So the first one absolutely resonated with me as well too. Like we need to get this feedback loop to show success stories. And it was actually funny, is just as you were saying that, I was thinking of one of our addiction fellows. His name is Aaron. He actually is EM trained at University of Michigan and is doing an addiction fellowship right now. And he's working on the BPA that pops up sometimes. It says like, consider sending the patient to the Bridge Clinic. And I was just thinking, like as you were talking, I was thinking about him, like he might be a perfect person to kind of be this liaison between the Bridge Clinic and feedback patients. And right as I thought that, an email from him just popped up. So like we just we just conjured him, which is like perfect for Halloween. um, but no, I think that's perfect. And so I'll reach out about that and see, because there are success stories. There's I work occasionally Bridge Clinic. In fact, I'm working there this afternoon. There's a patient that's she used to come to the ED like regularly, having a lot of difficulty organizing her life, and some of it's due to underlying behavioral health issues. But she would come to the ED, she'd wait for hours and hours, she'd be in withdrawal, she'd cause a ruckus, sometimes have to be thrown out, like this whole thing. Now she comes to the Bridge Clinic, no appointment, once a week, stable. She's been doing this for months now. She gets a 1 week prescription because the medications always get stolen. That's okay. And we just keep doing it. She hasn't gone to the ED in months. Like stories like that, I think are really powerful. That's a unique case. There's other stories where, yeah, you get people started and they like on the path to recovery and they get their lives back and their kids back and their family back. Like it's all good. And I don't think that we see that enough. So yeah, that, like you said, that resonated with me as well. And I think we should do that. For the second thing, we're going to talk about methadone as well. It's really, it kind of depends. So was the patient that you were asking about, are they in withdrawal now or they're not in withdrawal yet?
Yeah, so I think in withdrawal, but I think the case where I have seen this a couple of times has been the like in withdrawal and in pain.
Yeah.
And maybe not convinced that like, fractionating Suboxone is going to be the best strategy to control their pain.
Yeah. So methadone would be good in that circumstance. Um, you could, I mean, as you mentioned early in this talk, you could also go with a full agonist opioid, although that's a little bit more controversial because people are like, well, you've got a use disorder. Why are we giving them more opioids? But if they truly are in pain as well as withdrawal, that will take care of both of them. My hesitation with methadone is just two things, but doesn't mean you shouldn't use it, but two things. The first is the follow-up piece, right? It's important that they have follow-up arranged. And fortunately, now at the Mass General Bridge Clinic, they can continue methadone. And here at the Brigham, we're hopeful we're going to have it by like December, but we don't have it yet. So you can also send people to BMC faster paths. They can do that as well there. But you need some sort of a continuation plan for methadone. And
Does that mean, when you say continue, does that mean like they will come to the Bridge Clinic for a daily dose until they're set up with a methadone clinic?
Yep. So
Oh, cool.
there's the 72-hour rule, which again I was going to talk about a little bit later, but we can talk about it now, allows hospitals and clinics that are registered to be able to provide up to 72 hours of MOUD, including methadone. So they'll be able to do that in those clinics, and then that gives them time to get people to AHOPE or like other methadone clinics, and that's a pathway for them. Excuse me. The other thing I'm hesitating about is that transitioning from methadone to buprenorphine is a little nuanced. Since it's very long acting, methadone, you need to be off it for a while, like probably up to 72 hours before you start buprenorphine, and that can be an uncomfortable time for patients. You can see like if here it says methadone withdrawal commonly takes longer. I know we're talking about methadone withdrawal, but if you give a dose, then you might have to want to wait a little bit before you start it. But that's okay. Like ultimately, getting them out of withdrawal is the number one thing you can do for them. And if the solution for them, and nowadays patients do have experience with a lot of these meds, is methadone, use methadone. Does that make
That's
sense?
good. Yeah. No, thank you. Thank you. Sorry to interrupt you.
No, it's good. I get to catch my breath too. So let's see, Sharon just commented. Let me get the chat back. Oh yeah, so talk like this is a very patient-centered decision. Because things are very different between buprenorphine and methadone for a patient's life. Methadone, at least near the beginning, you have to go to a clinic, and that provides some structure for patients that I think is really important. To have a routine, go every day, go to the clinic, get your dose. But then you might not be able to bring your kids to school if you've got to go to every morning to the clinic. So it's a very personal decision as far as if that's the right medication for patients because of all these logistics around it. Buprenorphine, on the other hand, again, can precipitate withdrawal, so patients are often hesitant about that. And then there's issues around pharmacy, like some pharmacies don't carry it, some pharmacies like they might cost a lot of money for them. So it's really just I really just leave it up to the patient. Like, what have they heard? What have they had experience with in the past? What would they like to try? And just be as open as possible. we know from multiple studies that the outcomes are pretty similar between the two of them, with some variation between the studies. The most important thing is getting someone on one of those two. But I would really make it about them. And so I don't push one versus the other, but I do try and gauge where they are in their life and what would work better for them and make a decision that way. Does that make sense? Okay, cool. Let's continue on this pathway. So let's say that we think that we've had buprenorphine precipitated withdrawal. The most important thing down here is act quickly. Can you see my arrow? Okay,
Yes.
yeah. And we've gotten into trouble when we haven't acted quickly. So we actually had an M&M now several months ago of a patient that got like 4, and then they waited like an hour, and then they gave them another 4, and then they waited like an hour, and then I think they gave them 2, and it was just like far underdosing them, and that's really bad because the patient's in this like really bad withdrawal. So Aaron, when I asked you earlier, like the time period, I think you said 30 minutes. Perfect. Like I wouldn't do more than 30, 45 minutes before you address it. So act quickly. In this case, you're going to give another 16 milligrams. Typically, a maximum would be 32 milligrams that you're going to give in the ED. I have colleagues that will go to like 48. There's this one guy that will go to 96. It is possible there is a ceiling effect, but if I'm giving 32 and they're still having significant withdrawal, I am thinking there's something else going on. Oftentimes, precipitated withdrawal is actually just anxiety, and they're worried about the whole thing. So people have found that lorazepam as a single dose can help with anxiolysis, so you can consider that too. After 30 minutes, if they're improved, which the vast majority will be, you observe them for a bit and then you can discharge them, just like in the green box. If not, then you pull out other things from your toolkit. You can use the adjuvants, you can use olanzapine, clonidine. Already, if you've got nausea, you're going to be giving like ondansetron. And at the very bottom, if it's getting really bad, you can use ketamine, like pain doses, 0.3 mg per kg, or fentanyl. Again, I don't anticipate you're going to get to the bottom of this box more than like, once every couple of years. But I would think of this very similar to like how we think of the airway pathway, right? Like you're trying to debate, no, okay, we're gonna try bougie, no, okay, then we're gonna try an LMA or whatever, no, okay, then we're gonna like you're gonna do everything until you get to Crike. And this is the last thing. But it's important to know what to do in each case because you have to reassure patients, yeah, I know what to do with this as well. But yeah, ketamine works and fentanyl work. At this point, fentanyl works, but at this point, you're probably going to be admitting the patient because there's probably more going on that's tougher. And again, I don't expect that to happen very frequently. Questions? Okay. If you're discharging, so this says prescribe at least a 2-week supply. Our to-go packs at the General are 6 films. So that's basically a 2 or 3-day supply, depending on the dose that the patient is taking. And we don't have them yet at the Brigham and the Faulkner, but we're actively working on it, and I hope we'll get it out soon. Here at Brigham, you have to write a prescription for now. I think here we have such good access to Bridge Clinic that I think that just a couple day supply is fine. So like 3 days, 6 films, 8 films, something like that is completely fine in our environment where we have rapid access to Bridge Clinic. And then always remember to dispense naloxone. All right, that's a lot. But this is like the money slide. This is like the most important information, and I hope you could share this with colleagues too. Pull it up if you're on shift and you've got a patient. I think it's pretty clear, even though it looks kind of dense to begin with, but I think it makes a lot of sense. All right, for ASEP, we just released our simplified version of this. Some people get really intimidated when they see this, so it's very simple. Are you in withdrawal? At least 2 clear signs. Buprenorphine 8 to 24. We tried to make this for like all EDs around the country, so to make it really kind of broad applicability. If it's improved, you can consider additional doses and then discharge. If it's not, you give additional doses. If improved, discharge. If not, use the adjuncts. If improved, discharge. And if not, then your observation or admit. So really, it's like kind of cookbook at this point. Okay, next topic. So by the way, you've given the Suboxone to the patient, and she tells you she thinks she might be pregnant.
That's totally fine. Better to control the opioid use and prevent withdrawal for the fetus, and the medications we're giving her will be okay.
You went to the talk yesterday.
Yes, I did.
Yeah. Okay, but a little more nuanced. You've given her Suboxone. What is Suboxone?
Buprenorphine and naloxone.
Okay, and what's the naloxone there for?
It's to prevent misuse. So if you were to inject it, for example, it could precipitate withdrawal.
Have you heard that you shouldn't give that to pregnant patients?
Yes, but I think the mechanism of, or the way in which we're giving it is safe sublingually.
Yeah, Brendan, do you have a comment?
No, I agree. I feel like that is what you're always told, but I think people are saying that that's nonsense.
Yeah, you guys are awesome. So you got it. The initial thought was that you want to minimize whatever exposure you can to a fetus, right? So if you don't really need the naloxone in there, then don't expose a fetus to it. And so that's the reason why they recommend to use Subutex, which is just buprenorphine, versus Suboxone, which is buprenorphine and naloxone for pregnant patients. But the reality is that it's completely safe, is the bottom line. So this just came out like 2 months ago, and they found that there was no difference with respect to anything that they looked at regarding pregnancy for patients that had it. Um, buprenorphine with naloxone versus just buprenorphine, and actually, although it was like wasn't statistically significant, it looked like it was actually a little bit lower mortality for women that were, or for pregnant patients that were prescribed the buprenorphine naloxone combination. So I probably would still just prescribe the buprenorphine alone if I knew that they were pregnant, but I'm not sweating about it if they are pregnant and have given him. So, all right, just for your information, so there actually is a billing code to do this because it's a lot of work. And so you don't see increased revenue as a resident, but when you start to work as an attending, then that like goes into the calculation. It's not a ton of money, it's like $59 to do it, but that's better than nothing. And it really is, it just shows that the payers, especially in this case, Medicare and Medicaid, want us to do this. So I thought that was kind of interesting. All right. That patient comes back to you before you give the medication, says, "Look, I really don't want precipitated withdrawal. I've I've heard of this. My friends that did it, like had it, were just miserable. Isn't there something called microinduction?"
There
Ye-
is. What have you heard about it?
Do you know anything about it? Like Aaron, you're muted for a second.
Yes, I think there is, but I think like going back to the conversation earlier, we're kind of going away from that and starting higher so that we can, prevent precipitated withdrawal at higher rates.
Yeah, so this is a viable strategy. The original publication was called the Bernese method because it's from Bern in Switzerland. And so that's where the name comes from. I was just always curious. But the Bernese method is basically you start really low. And again, you're starting with zero point 0.5 milligrams as a starting dose. You might give 0.5 the first day. The second day, you might give 1 milligram, like 0.5 BID. The day after, you might give 2. Then you might give 2 BID. Then you might give 4. And the idea is that over kind of like 5 to 12 to 14 days, you're increasing very slowly the dose of buprenorphine. The reason this works is that if you think about the pharmacology, buprenorphine binds very, very tightly to the opioid receptor and will knock off other full opioid agonists. So as you're slowly increasing it, you're displacing the full agonist opioid, but in a way that's very gentle. And so the patient doesn't perceive much withdrawal. Couple caveats. Typically, patients will continue to use their full agonist opioid during the initial days. So you basically are going to tell them, yeah, keep using fentanyl, which is a little bit weird for us as healthcare like as physicians to tell patients to do that, but they're going to keep using it until they feel like they don't need it anymore. There's probably not a big use case for this in the ED. That's the way we don't talk about it. This is better for clinic, where you can closely follow patients over a few days, see if they need to like increase, decrease their dose. But if you do have a patient that's very interested in it, I wouldn't hesitate to give them like, 0.5 milligrams to take like QD or BID for a few days while they're waiting to get into the bridge clinic. That'll probably speed up their work going forward. I don't expect this to be a regular thing, but I think it's something to know about because patients certainly know about it. And then, doctors, isn't there a new buprenorphine shot you can give me? Have you heard of this at all? What do you know,
I'm
Aaron?
a fan. Yeah, I haven't actually seen it ever happening, at least in our EDs. I don't even know that I've seen any patients here that are on it, but it seems like it could be great.
Yeah, I'm really, really enthusiastic about this. So, it's called Brixadi. That's the commercial name. It comes as a weekly dose and a monthly dose. The weekly is a, it's getting a 7-day dose. And in this study that Gail D'Onofrio led, she's done at Yale, with a lot of people, including Liz Samuels that we met yesterday. They've just finished wrapping up their trial with about 2,000 patients, where they randomized them to the 7-day injectable versus just starting them on regular buprenorphine. And it seems like this is really, really nice because even for patients with low COW scores, the chance of precipitating withdrawal is really, really low. We're talking like 8 in 2,000, like really, really low. And so, and the nice thing is it buys you 7 days that you don't have to worry about the follow-up. You don't have to worry about filling the prescription. You don't have to worry about precipitated withdrawal. Like it's really nice. The downside is it costs, I think I heard around like $400. So reimbursement might be an issue. But this is something to think about. I have an email into our director of our P&T committee, who's we're going back and forth a little bit as of this morning, because I think we should get this on formulary. So we don't have it yet, which is probably the reason why you haven't seen it. It was just approved probably about, I don't know, maybe a year ago at this point. So it's still pretty new. But keep an eye out for this. It's not ready for prime time yet because we don't have availability, but I think this is going to be a nice solution for willing patients.
Scott, did they talk about it all in that study, like near the end of whatever time period the Brixadi is approved for? So like at the end, say of the 8 days or whatever, at the end of the week, were people experiencing higher rates of withdrawal at that time? Like, is it tapering? Does that make sense?
Yeah, no, so I don't want to misquote the study because not to my recollection. I don't believe that they had increased precipitated withdrawal. Their follow-up, I think, for withdrawal was like they looked at 4 hours and then I think they called them once a day. I have to just refresh my memory about that.
No,
But
sorry. Maybe I phrased it wrong. I guess what I mean is, were they starting to experience withdrawal 7 days later, like
yeah,
higher?
no, I understood the question. I don't know the
Okay,
answer to that question. Yeah.
gotcha. No problem.
And I'll look it up and get that back to you. But they did find that about 3/4 were engaged in treatment in 7 days, and maybe that was because they started feeling withdrawal, and so they wanted to follow up again. Because I do know that compared to something like Sublocade, which sticks around longer than the 30 days it's advertised as, this one is it's in a different medium, and it really does last like 7 days. It doesn't last a lot longer than that. All right. So let's move on to methadone. And I only have 10 minutes left, but we can chat another time too. But so 32-year-old male reports injecting fentanyl several times daily, ran out and wants to stop using, feels unwell, has been on methadone in the past and wants to start again. This is kind of like to Sharon's question about which one to start. What would you like to do?
I would love to start my methadone, but I think, like we were talking about earlier, I would just try to make sure first that we knew of a way to link him to care before we started him.
So let's say you're seeing them at the general. There's Bridge Clinic there 5 days a week. It's a Tuesday right now, and they can continue care.
Let's do it.
Do what?
Let's start the methadone in the ED.
What kind of dose do you want to give?
Ooh, I need to refresh myself on the initiation doses. I think it's like 10 milligrams for methadone, 10 to 20.
I feel like this is a trouble that we always get caught in between the patient and the pharmacist, where the patient's like, I was on 120 of methadone a week ago. 10 is going to do nothing for me. And I'm like, yeah, you're probably right. I think we can give up to like 30 or 40. I don't know, as a single dose. It might be like 20 and then 20 is like protocol. But I do wonder how we can negotiate that conversation where I think the patient does feel like we just don't understand them because they know their body. They know what methadone's done to them before. They know how much opioid requirement they have, and we're the ones who are full of shit.
I love that too because it's like patients really do know what's happening these days, and they know what their body needs. We also have to be like safe with them too, and we'll talk about that. And Sharon, I do see your response of 30 as well. I agree with that. So I'm going to skip through this. This is actually University of Vermont. Anyone heard of that institution before? Um, so this is their emergency department initiation, and I like it. It's kind of messy, but it's like it kind of puts together a lot of good protocols that I've seen. So the first thing is that they want methadone. I skipped through some of the contraindications to it, but just know like you don't necessarily have to check an EKG before starting methadone. But if there's any reason for it, like they're taking other QT prolongation medications, um, like TCAs, antifungals, macrolides, stuff like that, just be careful. And actually, if you're as you're just getting started, I probably would just check an EKG in the ED anyways. That's not evidence-based. It's just the fact that we check so many EKGs that I think it would put people at ease, especially if we're trying to convince them that it's okay to do this. And then the standard dose is yes, 30 milligrams. So that's perfect if you said that. And I would start with 30. I wouldn't start with 10. The initial protocol we had in our hospital was like 10, then wait, then 10, then wait, then 10, then wait. It's too long. I would just go to 30. And then and actually I think, yeah, this is what's currently in our order set. So many patients will tolerate an additional dose of up to 30 milligrams. And then you can give an additional dose as needed, 10 milligrams, but don't go up to beyond 40 milligrams without the involvement of an addiction specialist. So as you're talking to the pharmacist, just it's the inpatient opioid withdrawal order set. And this is exactly what it says. And you can say like, pharmacist, I love your insight, but this is what's in the protocol for the hospital. This is what I want to do. So I would do 30. I'd wait like 20, 30 minutes. If they're not better, I would go up to 40, and I wouldn't do more than that, um, just as an initial dose. It's just balancing like getting them without a withdrawal and safety as well. And then the other thing is gets to what you had mentioned, Brendan, before about continuation. If their last dose was within the last 72 hours, and you can confirm it, which I'll mention in a second, then you can give 100% of the dose. If it's between 72 and 120 hours, you're going to get 50% of the last dose. And if you can't confirm the dose, or it was more than 120 hours, then consider it new, and you're going to do a maximum of 40. 40 is enough to get people that even had a dose yesterday that they missed out of withdrawal until they get to the clinic the next day. But if they say like, yeah, I was on 120 and then my last dose was a week ago and I know I need 120, no, like the tolerance will kind of wane pretty quickly, and that could be dangerous to give them that high of a dose if we can't confirm it. So this is what I'd follow, and it's just written there in the withdrawal order set, so it should be pretty easy to follow. I want to say more about this, but any questions so far? Okay, great. So the way to find out to confirm their dose is right now on EM Web, which is now changing, I think, as of next month or something to a new platform, but the information will still be there. we recently uploaded this community-based OTP 24-hour dose verification list. So you can find this in Epic, and these are all the local treatment facilities. So if the patient says like, yeah, I'm followed at in Springfield on Liberty Street, and they don't know the number, well, here's a number, and you can just look it up and call them. Again, sometimes the clinic will be closed, and then at that point, I would just give them up to 40. I wouldn't give more than that until you can confirm it. And the reason we can do this is, again, something called the 72-hour rule. And this is, thank you, ChatGPT, for summarizing this nicely. But we are able to give up to 72 hours of medication for OUD, either opiate withdrawal management or treatment for up to 72 hours without needing a specific waiver or license or anything like that. And so we can use that. This is fairly new. As of like a couple of years ago, it only said for withdrawal management, and that was problematic for a patient that came in that missed their dose. But now they also added the word treatment. So we can continue treatment. It's a little tricky, like it sounds like this is not renewable, but that's a little fuzzy. Like what if a patient comes back 6 months later? I still would give it and just suffer the consequences later. I mean, you can always blame your attending, but this it shouldn't be something that's happening like once a week. I wouldn't do that. This is really something that's like sporadic enough to keep people started. Comments, questions for that?
I had no idea you could find that list of numbers. That's so helpful because I feel like I'm always Googling these programs to try to find how to get in contact with them. I know it's Brendan's dream to have like a centralized location online somewhere that we could see somebody's last dose. Is there any like barrier to that?
What do you mean? Like as far like a state-based thing?
Yeah, like a
You know, like
PDNP
if Mass
almost
Pat
for
included a
methadone.
last methadone dose.
Oh my God, we were just talking about that at dinner last night too. It would be like so wonderful, and it's so stupid that it's not included. I don't see any, excuse me, I don't see any imminent way that's happening, and the reason is really just logistics. That these methadone clinics, they don't have the software and the staff to be able to report to the PDMP like pharmacies do. And so it would take like revamping their computer systems that would then connect to the state to then report. But that the technology is there. It's just political will. So I'm gonna put this on you all as the next generation. Like do some advocacy and try and get our state house to do that. Because it's ridiculous that we don't have access to that. And it's actually it's having other ramifications as well. Like we're working on measures around MOUD care from the ED, and we can't see if they're already on methadone. And that's a huge problem because people are included in the denominator and not the numerator, even when they're actually being treated. So it spills over into quality, spills over into patient care. Yeah, it's a problem. Get off the
Let's do it,
soapbox.
Brendan.
We can do it.
Yeah.
We can get some buy-in from these clinics. Like, do you think they really enjoy confirming last dose over the phone? 6 a.m? Probably not.
Yeah, probably not. I mean, like it'd probably be the same thing as a PDMP where there's initial resistance, like, no, we don't want to do more work, to eventually like, oh yeah, this is really good. Yeah, I totally agree. I mean, there's also the 42 CFR Part 2. This is this federal regulation that says that addiction treatment is separate and confidential. People are always worried about that too. But we capture buprenorphine in the PDMP, so that's the same thing. Cool. All right. We were going to talk about a couple other patients. Maybe we could do that another time. What I'm just going to leave you the last 4 points. Actually, we'll do this here. So first of all, this is a paper that actually Liz cited yesterday. About 1 in 20 patients that you discharge after overdose is going to be dead in a year. This is actually old data. It's probably higher now. Please, please, please give naloxone. Give it liberally. If you need any for yourself, I've got a whole box of naloxone here. I wish I could hand it to you virtually, but I've got it. Thanks, Sharon. Yeah, let's work in the long run. I totally agree. And then we have harm reduction supplies available about both the Brigham and the General. Patient that's not ready for recovery still wants to use. Okay, we're not judging. We want to make sure that you're safe. We don't want you to get hepatitis. We don't want you to get HIV. Please use these. And they actually do have a pamphlet for both how to inject drugs safely and also like when you're ready for help. These are our resources that we have. You can order this in Epic. And then also there's a smart phrase, which is .sud harm reduction. So you just remember that. And then finally is that please just like refer really liberally to the Bridge Clinic. We really want to increase the referrals. So I'd rather you just bombard them with referrals. Of course, ask the patient first if it's okay to refer, but anyone you can think of, say, we've got this great clinic, we'll follow up. Can you please include, can we follow up? Can you follow with them? You can put their ambulatory referral in. The most important point here is please put in their most current phone number because frequently the phone number that they've got in Epic in registration is not correct. So that's the one ask that we have. And then no, the harm reduction kits don't come with Narcan, and the reason is simply because Narcan's a medication, it has to be stored differently. So you do have to order them separately. For the Brigham, it's a little bit of a hassle. Like you have to actually write a prescription and then print it and hand it to the pharmacist, and then they'll get it for you. Whereas the harm reduction kits are in one of the supply cabinets, and the ESA should know where it's at. It'd be nice to put them together, but it's just one's medication, it has to be stored differently. And there wasn't room to put the harm reduction kits into the Omnicell. So, all right, so I will end there, and hopefully that was useful. Thanks so much for the engagement. I really appreciate it.
That was super educational. Thank you so much, Dr. Weiner. Really appreciate you setting that up for us.
Yeah, pleasure. Anytime. People will know I'm always willing to talk about OUD.
Yeah, this is awesome. Thank you.
Cool. Have a great rest of your vacation, Brendan, and have a good shift, Sharon, if you're on shift.